My name is Joyce, as you have been informed, specialist hemoglobinopathy midwife in St. George's Hospital. I go straight because we have had a couple of discussions before about hemoglobinopathies. Now, all pregnant women who have unusual hemoglobin are offered counseling and screening of the baby's father with consent. However, some fathers may not be available for testing, the reason being denial of being a carrier of unusual hemoglobin sometimes could be playing part of that. Also, work schedule or fear of the sight of the blood, needles, phobia, and some other reasons that may be relevant to them. So they may decline or may not be available for testing. On this slide here, I've put something there which I struggle a little bit to see at the moment, but I hope you can see. It's about picture about this invasive procedure that is offered. However, women need to know what is normal, from normal to what is unusual, so they can understand from the normal to the unusual, being able to understand their condition and help them in the decision-making process. So this is the picture of that. And actually, it's also, we offer the screening for every pregnant woman. This is including IVF pregnancy, as the last time we discussed in our presentation. And so it's offered between 11 weeks to 20 weeks. And amniocentesis offered between 15 to 20 weeks. It can be offered at a later date, depending upon the circumstances. However, if women decline to have the P&D, there is also a pathway of care for them so that the babies are monitored for, to control mortality and morbidity. So they are offered, we discuss with them capillary testing and newborn screening at 5 days old. This is a story of patient A. She is a carrier and her husband her baby's father is also a carrier. They had a child who died, who passed away on neonatal death at 3 months of age. So her second child was also affected, or is also affected with sickle cell anemia. Then she became pregnant with her third pregnancy. She decided then to go for pregnancy P&D, which is pre-diagnostic testing. Forgive me, this is not how I am. She decided to go for pre-diagnostic testing. However, during the time that she'd been offered and the procedure to be started, she declined the procedure on the same day as she was about to take the P&D process, or CVS. And these are the following challenges that she was facing her and affecting her decision-making. In fact, in tears, she was complaining the labeling and the stigma and the rejection in her extended family. The fact that she has got a sickle cell child, she has felt lonely most of the time in taking the child to hospital, and it seems she wasn't getting any support. And the sister-in-laws sort of abusing her in some ways of the condition that she has, and has brought a sort of calamity upon the family. That is the word she has been using. In this case, it was very challenging for her to make a decision, either to go ahead with the process of the CVS or the P&D. The fear of miscarriage, which the CVS or procedure or amniocentesis procedure comes as a risk, is a very small risk. It's less than 1% in some cases, in some centers. But on average, the percentage of the risk of invasive procedure is about 1%. However, in some centers where this is carried out, the risk is less than 1%, which is about 0.7%. And so with this information, that's when it made her decide that she would go for the CVS to have the diagnosis. But however, she was afraid that she will have a miscarriage from that. She's also feared that she will have a child who is sickle cell, which means she's got one child who is a sickle cell disease, and she's going to have another child who is sickle cell disease. At this initial pregnancy time, and when we were looking for her for screening, we could not get through to her, and we thought that she had moved her house because she wasn't responding to her contacts, her mobile phones, not knowing that she was on admission in the same hospital with her child at 2 years of age. And so when we managed to get her, she was in tears again, crying to say that this is what she's facing, and that is what she's afraid to have again, another child who is also sickle cell. However, this is a one who has had a child who is complex. She has had a child who is died at 3 months of age, and it was because of sickle cell disease. She was also facing religious beliefs. The effect of it was that the religion that she's coming from, she's not allowed to terminate. However, in her and her experiences, she wished when she have that PND and baby is affected, she would terminate the pregnancy. And cultural religious beliefs as well. So these are the multiple of issues that was affecting her decision-making about the process or the PND. It wasn't just the PND, but because one, she has had a child who is affected by disease. Two, she's got a live child who is also affected by disease. And so she was contemplating and combining all this in the process. And it was quite challenging for her. The following is how we manage her. We gave her time and information to make decisions. And we respected every decision that she made. We had to respect her decision and go along with her. We had to involve multidisciplinary teams, the fetal medicine unit consultants, geneticists, neonatologists, and pediatric hematology team, specialist nurses in hematology were all involved in some way at every stage that the decision was made. Because when she was referred for PND, the consultant, fetal medicine unit consultants were involved. Genetics were involved for the counseling. Neonatologists were involved when the baby had capillary testing. The biomedical scientists were all sort of contact, not involved as a general, but contact in order to ensure a safe care for the baby. Because the main reason is to control mortality and morbidity. And that is what the way we took her. And that is approach is done with everyone that has a complex need and to have to make a complex decision. So the message to take home is that early screening for all pregnant women who are at risk is essential in the screening process. This includes IVF pregnancies. Screening the father of the baby is very, very important, and it's also to gain consent, because for them, they deny that they are carriers. It's very common with them. They also, because of their family, sometimes when they are going to have the test, they don't want their families to know because of the stigma and the rejection that they face in the family and in the culture. So it's not easy for this group of people or the people who experience haemoglobinopathy. As I mentioned the last time, when you have a disease, it's a problem. When you are a carrier, it's a problem, because families don't want families to marry anyone who is a carrier because of the risk that they are going to have a child who is affected with a haemoglobinopathy disease. And so this is the problem that is there, but with respect, care, and support, they can make decisions about their pregnancy. So it's important to discuss options earlier at onset and possible outcomes and offer the PND. And it's important to be aware of the challenges and dilemmas they face, the fear, the stigma, the labeling, the cultural and religious beliefs. With adequate information, support, understanding, respecting their decision-making, they are able to make choices that are suitable for them and their families. Thank you.
Thanks for watching this video from the Maternity and Midwifery Forum. For more expert opinion and analysis, hit the button below to subscribe.